Hello guys, you're welcome to Alicia's Medical. Today we'll be discussing pharmacology and our topic today will be thyroid hormones and antithyroid drugs. So I'm going to give a brief overview of the thyroid gland, the anatomy of the thyroid gland. Now the thyroid gland is a two-lobed gland that an originates from an invagination of the floor of the pharynx and thyroglosal duct. It is composed of multiple follicles. Each follicle has thyroglobulin, colloid filled lumen, which is the stored form of thyroid hormones. The parafollicular cells surround the follicles produce calcitonin. Now, for the biosynthesis of thyroid hormones, the thyroid hormones are iodinated amino acids. Uh, Tyrosine is the amino acid. So, the amino acid involved in the production of thyroid hormone or biosynthesis of thyroid hormone is the tyrosine. Now, the normal thyroid gland secretes three hormones. These hormones are the thyroxine, which is T4, the triiodothyronine, which is T3, and the calcitonin. Now, the steps involved in the biosynthesis of thyroid hormone include the uptake of plasma iodide, the oxidation of iodide and iodination of tyrosine residue, which is the organification of iodine, and lastly, the storage and the secretion of thyroid hormone. Now, for the biosynthesis of thyroid hormone, uh, we will talk about the uptake of plasma iodide. Now, iodide is transported into the thyroid gland by intrinsic follicle membrane protein called sodium iodide synthetase. Sodium iodide synthetase is the transport channel by which iodide is transported into the thyroid gland by intrinsic follicle. Now, pendrin controls the transport of iodide at the apical cell membrane. The deficiency of pendrin leads to Pendred syndrome. The deficiency of pendrin leads to Pendred syndrome, which is characterized by goiter and deafness if cochlear deficiency occurs. So the next step, which is the oxidation of iodide and iodination of tyrosine residue. Now, at the apical cell membrane, iodide is oxidized to iodine by thyroidal peroxidase. So the enzymes that is involved in the oxidation of iodide to iodine is thyroidal peroxidase. Now, iodine organification or iodination of tyrosine residue of the thyroglobulin in the gland leads to the formation of monoiodotyrosine, that's MIT, and diiodotyrosine, which is DIT. Coupling of two molecules of DIT, that's diiodotyrosine, gives the L-tyrosine, which is T4, while the coupling of one molecule of DIT, that's diiodotyrosine, and MIT, which is monoiodotyrosine, results in the formation of triiodothyronine, which is T3. Now, for the storage and secretion of thyroid hormone, biosynthesized thyroid hormone are stored as thyroglobulin in the lumen of the follicles of the thyroid gland. The release of T4, T3, which is um, tetraiodothyronine and triiodothyronine, tetraiodotyrosine and triiodothyronine, MIT, monoiodotyrosine, and DIT, which is diiodotyrosine. From thyroglobulin at the apical colloidal border is by exocytosis and proteolysis. The synthesis of thyroid hormone is under the control of thyroid stimulating hormone. So, from the anterior pituitary gland. So, thyroid stimulating hormone controls the synthesis of thyroid hormone, and thyroid stimulating hormone is synthesized from the anterior pituitary gland. Now, the release of thyroid hormone is controlled by thyrotropin releasing hormone, is a tropic hormone produced by the hypothalamus. In humans, about 80 microgram, which is about 103 nanomole of T4, and 4 microgram, which is about 7 nanomole of T3, and 2 microgram, which is about 2.5 nanomole of reverse T3, are secreted daily. Now, the transport and peripheral metabolism of thyroid hormone. Thyroid hormone binds reversibly to the thyroid binding globulin, which is a plasma protein, is a transport protein. Only about 0.04% of the total T4 and 0.4% of T3 exists in the free form to exert metabolic effect. Now, T3 is 10 times more potent than T4, right? So note that T3, it is more efficient, more effective, more active compared to T4. Now, in peripheral tissues, which include the liver and as well as the kidneys, T4 is converted to T3 by deiodination, catalyzed by microsomal iodotyrosine dehydrogenase, the enzyme which is involved in the deiodination of T4 to T3. The deiodination of T4 results in two forms. It results in two forms of T3, which include the T5 3 prime thiiodotyronine, which is active, which is the active form, and T3 prime 5 prime thiiodotyronine, which is the inactive reverse T3. Now, the pharmacological effect of thyroid hormone. Now, the thyroid hormone enters the cell. T3 binds to thyroid receptor in the nuclei, right? Um, then the thyroid hormone receptor complex, which is the interaction between thyroid hormone and the receptor, then binds to DNA, that's deoxyribonucleic acid, to elicit the necessary action. Now, so one of the pharmacological effects of thyroid hormone is growth. Now, how does it bring about growth? Thyroid hormone is essential for normal growth and skeletal maturation. Bone growth is slow and epiphyseal closure delayed in bone growth is slow and epiphyseal closure is delayed in hypothyroid children. So children or infants who has a thyroid gland that is not as active as it's supposed to be, they will undergo or experience slow growth, and epiphyseal closure will be delayed. That's just what he's saying. So secretion of growth hormone is depressed in the absence of thyroid hormone. So that's why there's a retard growth, there's slow growth, right? So now another pharmacological effect is metabolism. Thyroid hormone increases the rate of absorption of carbohydrates from the GIT, that's the gastrointestinal tract. In hyperthyroidism, there's a rapid rise of plasma glucose occur after carbohydrate meals, followed by rapid falls. Thyroid hormone increases the formation of hepatic LDL, which is low density lipoproteins receptors, and as such lower circulating cholesterol level by facilitating the removal of cholesterol from the circulation. At large doses, thyroid hormone causes extra heat production, resulting in slight rise in body temperatures. Now, the activation of heat dissipation mechanism also occur. Now, it also has another effect in the cardiovascular system. Thyroid hormone stimulate the release of catecholamines, causing increase in the rate and the force of contraction or contractility of the heart. Thyroid hormone decreases peripheral resistance, resulting in cutaneous vasodilation. That is, it causes decrease in peripheral resistance, resulting in expansion of peripheral blood, right? Cutaneous blood. So sodium ion and fluid retention occurs, causing increased cardiac output. So it also has a pharmacological effect on the nervous system. Thyroid hormone enters the brain in adults and are found in the gray matter. They have marked effect on the brain development, which includes cerebral cortex, the beta ganglia, and the cochlea of the inner ear. The deficiency of thyroid hormone during development causes mental retardation, motor rigidity, and deafness. There's they also increase responsiveness to catecholamines, hence increase activation of the reticular activating system. Now it also has effect on the skeletal muscle as well. In hyperthyroidism, thyrotoxic myopathy, which is muscle weakness, occurs due to increase in protein metabolism. That's increase in the degradation of the protein, increase in the breakdown of the protein. That's just all it's saying. So it will cause it is known as thyrotoxic myopathy, that's muscle weakness. Similarly, in hypothyroidism, muscle weakness, cramps, and stiffness also occur. Now, conditions of the thyroid. And one of the example or the common examples, goiter, which is also known as thyroid swelling. Goiter can be harmless or may represent iodine deficiency or a condition associated with thyroid inflammation called Hashimoto's thyroiditis. It's an autoimmune condition. Hypothyroidism, thyroid, another condition is hypothyroidism. Now, thyroid damage caused by autoimmune disease is the most common cause of hypothyroidism. Another condition is the hyperthyroidism. Hyperthyroidism is most often caused by Graves' disease or an overactive thyroid nodule. Another example of thyroid condition is thyroid storm. It's a rare form of hyperthyroidism in which there's extremely high thyroid hormone level causing severe illness. Another example is the Graves' disease. It's an autoimmune condition in which the thyroid is overstimulated, causing hyperthyroidism. Then we have thyroid cancer. Thyroid cancer is usually curable by either surgery or radiation, and hormone treatment may be used to treat thyroid cancer. Then we have thyroid nodule, which is a small abnormal mass or lump in the thyroid gland. Thyroid nodules are extremely common. Few are cancerous. They may secrete excess hormone, causing hyperthyroidism or may cause no problem at all. Now, so for hypothyroidism may occur due to primary disease, that's a congenital hypothyroidism, immune, which is Hashimoto or iron deficiency. So primary hypothyroidism could occur as a congenital, as it could occur as a congenital hypothyroidism, like it's occurred. Um, it is you're born with it. It's a congenital anomaly. So then it could be immune. It could be immune. That is Hashimoto, or it could be as a result of iron deficiency. It results in low levels of free T4 as well as T3. Why the thyroid stimulating hormone level rises. Now, secondary or tertiary hypothyroidism, pituitary failure, um, pituitary hypothyroidism or hypothalamic failure, hypothalamic hypothyroidism results in low level of T4 as well as low thyroid stimulating hormone TSH levels. Now, the common signs and symptoms include fatigue, cold intolerance, weight gain despite reduced appetite. The individual is gaining weight despite a reduced appetite. There's irregular menstruation, there's poor memory, and in severe cases, there's mixed edema, which is non-pitting edema. Now, for hypothyroidism, the common causes it could be as a result of autoimmune disorder, Hashimoto thyroiditis, as we have said earlier. It could be as a result of drug. It could be exposure to radiation. It could be pituitary tumors. Now, for the treatment for these, the drugs we give are levothyroxine sodium, DOC for infantile and adult hypothyroidism. They would give TSH suppression therapy post-treatment of thyroid cancer. Nalothyronine sodium, treatment of myxedema coma, hypothermia, respiratory depression, and unconsciousness. It is also called now hypothyroidism. Now we're talking about hyperthyroidism. Now it is also called thyrotoxicosis or Graves' disease. Now the signs and symptoms associated with thyrotoxicosis include nervousness, excess sweating, hypersensitivity to heat, weight loss despite increased appetite. What are the causes of this hyperthyroidism? And number one, or the most common cause is Graves' disease, which is diffuse toxic goiter. We will have solitary toxic adenoma. We will have toxic multinodular goiter. We will have thyroid stability hormone secreting pituitary tumor. Subacute thyroiditis, which is viral or Hashimoto's. A mutation causes constitutive activation of thyroid stimulating hormone receptors, administration of thyroid hormone, ectopic thyroid tissue. Now, for the drug treatment, we give drugs such as thioamides, which include um, methimazole, propylthiouracil. We could give iodine salt. We could give radioactive iodine. Then adjuvant treatment, which include propanolol, metoprolol, atenolol, dithiazam, barbiturates. Now, then lastly, surgery. Thyroidectomy is the treatment of choice for patients with large glands or multinodular goiter. So surgery is um, the treatment of choice, right, for large goiter or multinodular goiter. Now, so for thyroid storm, it's also called thyrotoxic crisis. It is a life-threatening medical emergency characterized by extreme hyperthyroidism. Vigorous management is required. Now, the causes. Surgery could be a cause. Stress in patient who is already thyrotoxic. Now for treatment, we give thioamide, we give propylthiouracil, 250 milligram, 6 hours, or methimazole, 30 milligram OD. Or we could give potassium iodide, 10 drops, PO, that's post-op daily. We give beta adrenoceptor calcium channel blockers. We give glucocorticoids to protect the patient from shock and block rapid peripheral conversion of T4, that's deiodination of T4 to T3. Now, antithyroid drugs. Most antithyroid drugs inhibit thyroid function either by interfering with iodide trapping mechanism or by blocking organification and coupling steps. Remember the steps we outlined at the beginning of the course for the biosynthesis of thyroid hormone. So the drugs, antithyroid drugs, are designed to interfere at any of those steps. So they could, depending on the mechanism of action of the drug, it could either interfere iodide trapping mechanism or blocking organoification as well as coupling step, right? So they are classified into thioamides, iodides, ionic inhibitors, radioactive iodide, iodinated contrast media. Now, thioamides, example of thioamides includes methimazole, MMI, carbimazole, and propylthiouracil. They are sulfur-containing molecules. Methimazole is 10 times more potent than propyluracil. It is administered per oral. PO is per oral. Carbimazole is a prodrug. It is converted to methimazole after administration. Carbimazole and methimazole exhibit similar pharmacokinetic profile. Methimazole is nearly completely absorbed enterically after metabolism in the GI and first passed first pass through the liver. Methimazole does exhibit significant inter-individual variability in serum level. Excretion occurs through hepatic, renal, gastrointestinal feces, as well as bile. Propyluracil, 80% to 85% bound to plasma proteins. So roughly you have about 20 to 15% that are in the free form, right? So propyluracil has an absorption half-life of 60 to 75 minutes, and the elimination of half-life is approximately 1 hour. Okay, so the mechanism of action of thioamides, the mode of action is not fully understood. However, they prevent organification of iodine and the coupling of thyroglobulin molecules by inhibition of thyroperoxidase catalyzed by the reaction. Now, inhibition, if you could, if I'm going to, leave a link below where you could go back to, you could, or take the video back, right, and rewatch it so that you understand those steps. So you know where this thyroperoxidase is catalyzing and what's doing actually. So, in addition, propyluracil reduce the iodination of T4 to T3 in the peripheral tissues. So it prevents the formation of reverse T3, right? So now the side effects of thioamides includes common side effects are neutropenia, GI stress and nausea, maculopapular pruritic rash, drug fever, pain in the joints, headache. The rare adverse effect includes agranulocytosis, lymphadenopathy, exfoliative dermatitis. Now, ionic inhibitors, they are monovalent ions, right? Examples are perchlorate, pectinate, and thiocyanate. Mechanism of action include competitive inhibition of iodide transport mechanism, and as such, block iodide uptake by the gland. And the therapeutic uses include the therapeutic use includes for the treatment of sodium perchlorate, or potassium perchlorate is used for the treatment of amiodarone reduced hyperthyroidism. The side effects include aplastic anemia, For this reason, it's rarely used. Now, iodides, the main antithyroid drugs before the introduction of iodides are the main antithyroid drugs before the introduction of thiamide. Example include potassium iodide, sodium iodide, Lugo solution. Now, greater than 90% of them are absorbed from the GI. They are widely distributed in the extracellular fluid and is excreted by the renal system. Mechanisms of action include large doses greater than 6 milligram per deciliter. They inhibit thyroid hormone release by the inhibition of proteolysis of thyroglobulin. They decrease the size and vascularity. They decrease the size and vascularity of hyperplastic gland. Therapeutic uses of iodide can be used for preoperative thyroidectomy, for thyrotoxic crisis, that's thyroid storm with propanolol, cutaneous sporotrichosis, and lymphocutaneous sporotrichosis. It can reduce hyperthyroidism or precipitate hyperthyroidism. That's John-based dual phenomenon. Now, the side effect includes anaphylactic reaction, rash and fever, mucosal membrane ulceration, excessive lacrimation, and conjunctivitis, those related cold-like syndrome. Now, the radioactive iodine, um, this is an example here. It emits alpha and beta radiation. It's administered per oral a solution of sodium salt. It is easy to administer. It is effective and inexpensive, and it does not cause pain. Now, the dose calculation of radioactive iodine is giving dose of 75 to 200 mils per gram of the thyroid gland per 24 hours. Radioactive radioactive iodine micro microcuri 24 hours radioactive iodine radio radioiodine uptake after about 24 hours. I'm sorry. Now, the mechanism of action, the alpha components are cytotoxic, right? They destroy the thyroid parenchyma cells, evidenced by epithelial swelling and necrosis, follicular disruption, edema, and leukocyte infiltration. Now, the therapeutic uses of radioactive iodine include it's used in the treatment of hyperthyroidism in adults of 21 years and above. It's used in the treatment of refractory Graves' disease or subtotal thyroidectomy. It's also used in thyroid cancer. Now, the side effects include neck tenderness and swelling, nausea, swollen salivary gland, loss of taste or taste changes, can cause dry mouth, insufficient salivary production, can cause dry eyes, can result into excessive tearing from the eyes, high incidence of delayed hypothyroidism. Now, the contraindication is contraindicated in pregnancy. Um, desire to become, or that's women who are pregnant and women who desire to become pregnant in the next 12 months. Now, it is contraindicated in breastfeeding mothers, moderate to severe eye disease, suspicious thyroid nodules, so need for early control of hyperthyroidism. Thank you so much for listening. Please kindly like and subscribe. And of course, share. Thank you.